So next short station will be covering the central nervous system. This is about cerebellar tumor. When you get a gait instability, then they get a stem that patient is having gait instability and coordination problem. When you get this type of, you have to do the examination. Gait instability and coordination means you have to think of cerebellar tumor. So I want to examine your balance and coordination. This involves some walking test and checking. Then you look for the gait, tremor, dysarthria, nystagmus, spatial interpretation, sitting, gait for a few steps, wide base, heel to toe test, rhombic test, upper limb tone, reflex, finger to toe test, dysdiadokinesia, rebound test, lower limb heel shin test, toe reflexes, speech, British Constitution, baby hippopotamus, cranial nerves. So say for this 10th, shrug the shoulder, and 10th, 11th, 12th nerves. Then summary, say all positive findings. Then the questions will be, what are the main functions of cerebellum? Coordination of the movement, maintain balance and posture, control eye movements. Motor learning, calibration. Three functional divisions of cerebellum: vestibulocerebellum, flocculonodular lobe, balance and eye movement. Vestibulo, balance, eye movement. Spinocerebellum, vermis intermediate, gait and posture. So balance, eye movements, vestibulo, spinocerebellum, gait, posture, cerebrocerebellum, limb coordination. Which cranial nerves can be affected by posterior fossa tumors? Here it involves 4, 5, 6, 7, 8. So cerebropontine angle, vestibular. Further investigation, MRI of the brain, contrast, ghost and audiometry if eighth nerve is involved, ophthalmoplegia, papillodoma, blood, foreign fluid, blood count, urea, electrolytes and coagulation. Differential diagnosis, cerebellar signs, stroke, abscess, alcoholic, cerebral degeneration, paraneoplastic cerebral syndrome. Differential diagnosis, posterior fossa tumor, cerebral astrocytoma, medulloblastoma, hemangioblastoma, dermoid, brainstem gliomas, primary neuroendocrine dermal tumors, ependyma, choroid plexus papilloma. Management, investigations, plain X-ray, calcification, MRI, brain, gadolinium test, CT brain, whole body to check primary guided biopsy. Treatment is debulking, CUSA excision. So this was about the cerebellar tumors. Then you come towards the CNS examination, cranial nerves. So what you do, there are different stems. Middle-aged woman by GP for headache, perform cranial nerve examination. Other stem can be head trauma, perform examination of the cranial nerves. Then there can be a female patient with anosmia, visual defect, memory issue, perform cranial nerve examination and assess memory, MMSC. So what to do, just all 12 cranial, I will examine that these cranial nerve are demonstrated already. Then so questions will be bitemporal hemianopia, optic chiasma. Where is the lesion? Bitemporal hemianopia, lesion will be in optic chiasma. Symptoms will be papillodema, headache, vomiting, projectile, focal neurological phase, hypopituitarism. So increase hyperpituitarism means pituitary glands increase growth hormone, acromegaly, increase prolactin. Suggestive of acromegaly, enlarged hands and feet, progantism, carpal tunnel, macroglycia, prominent forehead, hypertension, coarse features. Hyperprolactinemia, galacturia, males erectile dysfunction, amenorrhea, infertility. Management is investigation, prolactin, hormone, growth hormone, MRI, gadolinium treatment. Treatment is medical, bromocriptine, dopamine, agonist, surgical, transfrontal. So head trauma, road traffic accident, perform ear examination, cranial nerves. Here inspection of the ear, bruising, laceration, mastoid, vital sign, tympanic membrane, leak. So otoscopy has to be done, leak and hemorrhage, discharge blood from the CSF, palpation, tenderness or the mastoid, crepitus signs, otoscopy. Hold like a pen, and pull the ear on the opposite side. Insert gently, see wax, foreign body, discharge, redness, swelling, infection, tympanic membrane, cone position, perforation, fluid from this. So next then check the cranial nerves 7 and 8. So cause of conductive hearing loss, hemotympanium due to skull base fracture. Cranial nerve to examine is 7th and 8th. Common causes of conductive deafness, wax, foreign body, otitis media. Structures on otoscopic view, pars flaccida, tensa, malleus, incus, stapes, cone of light. Management of hemotympanium, initially ATLS protocol, CT brain to access fracture base skull, audiometric check, hearing loss, ENT review, beta transferrin to CSF photoria. Female patient, anosmia, visual defect, memory loss, memory issue, perform CNS. So mini mental state test, you have to ask for questions 10 points, ask for the day, date, name of the place, city, registration 3 points, say 300 apple, table, penny, ask the repeat, Attention and calculation, 5 points, subtract 7 from the 100, recall 3 points, 3 words from earlier language. So name 2 objects, repeat if, buts, ands, follow the 3-stage command, read and open command, write the sentence, copy this figure. So question and answers will be: what drug will be given for this head injury? Dexamethasone. What will consult neurosurgeon? Cranial fossa tumors will be meningioma, olfactory neuroblastoma, cynomalignancy, secondaries, fundoscopic finding, papillodoma, increase in trachea pressure, atrophy, chronic disease, vitreous hemorrhage, tens, other hemorrhage secondary to is management is CT scan, investigation, the gadolinium scan, stereotactic biopsy, neuro-oncology, multidimensional treatment, stereotactic biopsy, debulking, and radiosurgery, gamma knife.